Keto Doc channel to everyone, and today I am going to teach you the topic of diarrhea in pediatrics. So let's start. First of all, the definition of diarrhea. Diarrhea, as per WHO, diarrhea is defined as passage of 3 or more stools per day, or passing of more stools than normal for age. Then incidence. Diarrhea causes 1.5 billion to billion deaths globally per annum. In India, the mortality is 1 in 5 children that die of diarrhea every year. The causes of diarrhea include contaminated food and water, and it is mostly viral. For example, rotavirus, norovirus, etc. Now, classification of diarrhea. Diarrhea is classified under various categories. The first one is based on duration. Based on duration, diarrhea is classified into acute diarrhea and chronic diarrhea. Then, based on physiology. Physiologically, diarrhea is classified into secretory diarrhea, osmotic diarrhea, exudative diarrhea, inflammatory diarrhea, motility diarrhea. But this classification is not as important as the first classification as per Bhaiva. So this is how it is classified based on physiology, inflammatory, secretory, osmotic. This is a flowchart. Do draw this in exam. Assessment of diarrhea. Based on diarrhea can be assessed based on the incidence of episodes of stools. That is mild diarrhea, which is less than 5 episodes in 24 hours. Moderate diarrhea, 5 to 10 stools in 24 hours, and severe diarrhea, more than 10 stools in 24 hours. Just remember 5 and 10. Less than 5 mild, more than 10 severe. Evaluation. How to evaluate a patient who is presenting to your OPD? So stepwise, first step is proper history, second step is physical examination, third step is lab examination, fourth step is stool culture, and other tests can be made. Now, clinically, how do you classify diarrhea? Clinically, diarrhea is classified based on presence or absence of danger signs. So these danger signs actually define the severity of diarrhea. What are these danger signs? Lethargy, sunken eyes, poor feeding, skin pinch. That is, do you know how to check for skin pinch? Skin pinch on abdomen, just to pinch the skin and check the retraction of the skin. Now, this pardon me for this poor flowchart. This flowchart shows the classification and treatment of diarrhea. The plans. There is the plans are plan A, plan B, plan C. As you have for exam preparation, plan A if everything goes alright, plan B if plan A fails, and plan C is the last backup plan. So plan A. Plan A is implemented when the patient is alert and active, the eyes are moist, tears present, that there is no sign of dehydration. Oral mucus the patient drinks normally, so there is no dehydration. You try to replace everything orally. In plan B, the patient though is conscious but irritable, signs of dehydration are present. How do you check for signs of dehydration? On eyes, whether it is dry or moist, tears, whether they are produced or not, oral mucosa, all mucous membranes show signs of dehydration. If the patient drinks vigorously, drinks normally is good, drinks vigorously, okay, acceptable, but skin pinch goes back slowly. Okay, so this is some dehydration. If in case of plan A, you treat the patient on OPD basis. In plan B, admit this patient and just correct the dehydration, then send the patient home. Plan C, this is the most critical stage. It is carried out in the most critical phase when the patient is drowsy and sleepy, the eyes are dry, tears are completely absent, oral mucosa is also dry, the patient, mostly the patient don't drink, skin pinch goes back very slow, and urine output is absent. These all are indications of severe dehydration, and this patient need to be admitted with immediate initiation of IV treatment. Now, correction of this dehydrations. Mild dehydration, moderate dehydration, severe dehydration. Let me give you a hack point. To remember such a big table, just remember the middle part. I'll tell you the how to. Ask the patients about number of episodes of blue stools per day. Remember 4 and 10. Less than 4 mild dehydration, more than 10 severe dehydration. Vomiting, if it just remember, it is very frequent in severe dehydration. Thirsty, as I explained in signs of dehydration, drinks normally, then it was in plan A. Similarly, if it is more than normal but acceptable, it's mild. If same remains for moderate dehydration, but if the patient does not drink, it is a danger sign. So it considered as severe dehydration. Similarly, urine output. When urine output is absent, it is severe dehydration. Look, look-wise, drowsiness, unconscious, it is danger sign of dehydration. Therefore, keep it in severe dehydration. Irritability, like I described before, it is to be kept in moderate dehydration. Tears, similar for tears and others. Skin pinch also. Now, this is the IMNCI classification of management of diarrhea. So, pink in the pink box, look for the danger signs that I described earlier. This is just a repetition. Remember, lethargic, sunken eyes, not able to drink or drinking poorly, and skin pinch goes back very slowly. So, this is classic danger signs are present. Therefore, this is severe dehydration. How to what are the treatment do you do? First of all, you have to admit the patient, and if you cannot treat, then you have to refer to higher center. If child is 2 years or older, you suspect cholera if cholera is present in your area, and go for yellow sign, yellow box. In yellow box, two of the signs may be present. So patient is irritable, sunken eyes, drinks eagerly, and more than normal, and skin pitch goes back slowly. This is some dehydration. Treat orally and give fluids, zinc supplements for, and give brad-secatide. Brad-secatide, do you know? In Nelson, it is bread, rice, curd. This order mentioned, but it's a high order. And then go for no dehydration. In no dehydration, there are not enough signs of dehydration. Just give fluid, zinc supplements, food to treat diarrhea. Advise mother and counsel about severe signs of dehydration and when to return to the clinic and follow up in 5 days. Now, principles of management. To manage management of diarrhea is fast, but what are there are 4 basic principles you have to take care during management. Just correct. First step is correction of dehydration. So this is a planning. Correct dehydration. Next step is correct the underlying cause which is triggering diarrhea. Then maintenance of nutrition so that the patient does not precipitate diarrhea. Fourth is prevention of incidents by educating the mother. Fluid replacement in planning. In planning, counsel the mother on 4 rules of home treatment. Give extra fluids and zinc supplements. Give as much extra fluid as the child takes. The principle of management of diarrhea is fluid, and fluid. Give as much possible fluid to patient and correct the dehydration. Less than 2 years, 50 to 100 ml after each loose stool, and more than 2 years, 100 to 200 ml after each loose stool, and continue feeding for 10 to 14 days. Now, this is the plan B. This is a chart you have to remember. Nobody at all asks this in exam. Don't worry about this. Okay. Now, oral fluid of choice in diarrhea is ORS. Do you know what is the composition of ORS? As per WHO ORS formula, ORS packets as per WHO comes in 25 gram, 0.5 gram packets, and the composition in milli equivalent wise, it is not so important. Just remember, sodium is equal to glucose. Okay, sodium is equal to glucose, that is 75 milli equivalents. Do you remember this is secondary active transport inside the LI, inside the SI of inside the SI? In that, sodium and glucose are transported by secondary active transport. That is why for 1 molecule of sodium, 1 molecule of glucose is required. So to correct electrolyte imbalance, you have to give glucose. Next is chloride. Chloride comes 65 milli equivalent. Potassium and citrate. Potassium comes 20 milli equivalent and citrate comes 10 milli equivalent. Adding up, total it comes around 290 to 320 milli equivalent. Adding up, it comes 230 and 230 milli equivalent, while the normal osmolarity of human plasma is 290 to 320. So we are correcting by hypoosmolar correction, so that we can correct replenish fluids rapidly. There's also called resomine, dehydration solution for malnutrition, in which aggressive approach for correction is not done. It is isoosmolar to plasma. Okay, there sodium is 40 milliequivalent per liter, glucose is 125 milliequivalents, remaining all are almost similar. Don't worry, nobody asks in the exam. It's just a higher order. Alternate fluids that are used for home management. You can give coconut water, salted rice water, buttermilk, yogurt. Don't give tea. Don't give fruit juice, cold drink, beverages, and caffeinated drinks. What happens? Fruit juice, these are hyperosmolar. They contain a lot of fiber and they're hyperosmolar. They draw all possible fluids from the plasma and increase dehydration. As I showed you in the initial classification, osmotic diarrhea, they initiate the osmotic diarrhea process. The plan C. In plan C is when plan A, plan B, both of it fails. So in plan C, you give IV fluids only, and the fluid of choice is Ringer's lactate. This is the WHO plan C. Just remember one crutch. It's a long table, but I will make it easier. Remember 30 and 70. 30 ml per kg and 70 ml per kg. You will correct the fluid by 100 ml per kg, but it is divided into 30 ml per kg, 70 ml per kg. 30 ml per kg with the bolus and 70 ml per kg with the maintenance. Remember, a less than 1 year and more than 1 year child. Less than 1 year child, छोटा सा बच्चों, you cannot correct fluids rapidly, you cannot give aggressive approach, so you have to correct it over 6 hours. See, divide 6 hours into 1 hour and 5 hour. Bolus correction, that is 30 ml per kg, is given over 1 hour, and 70 ml per kg it is given over remaining 5 hours. Now go for the more than 1 year old child. You can give an aggressive approach where 30 ml per kg is given over 30 minutes and 70 ml per kg is given over 2.5 hours. Okay. That's all. That is the basics of management of diarrhea. Thank you.